All right. Hello, everybody, and welcome to our conversation about menopause and migraines. As you all know, I am super excited for this conversation. Dr. Jennifer Roelands is here with us this evening to tell us about some recent updates on what's going on in the world of hormone replacement therapy for those of us who are in or around menopause. And we are going to talk about what it means specifically for those of us with migraine, specifically those of us who have migraine with aura. What are the risks? What are the benefits in terms of our overall health? And what is estrogen toxicity anyway? So we've got some fascinating topics for you guys here this evening. We will start with our conversation and then we'll just open it up to you guys. So if you want to put questions in the chat as we go, what I'll do is kind of keep an eye on those. So Dr. Rollins, you don't have to do that. You can just concentrate on your thing. And I'll keep my eyes on the questions in the chat and kind of try to group similar questions together. And if we can't quite fit it in while she and I are talking, we will for sure fit it in during the Q&A after. Okay? Sound good? All right.
Sounds great.
Get rolling. All right, Dr. Rollins, thank you so much for being here this evening to talk to us about menopause and migraines. And I think really the first question on my mind is that I know that we had the Women's Health Initiative, I don't know, 20-ish years ago that told us that hormone replacement therapy increased our risk of breast cancer. And then there's been some new updated information recently that says, well, maybe not, and maybe we should be on it. Can you just kind of walk us through how all that happened and where we're at now? What do we understand now about HRT during perimenopause and after?
Sure. Yeah, I'm happy to. Thanks for having me here. So the Women's Health Initiative was published in 2000. So it's been about 24 years since the study was published. And at the time, the way the study was grouped is that it had estrogen only, estrogen plus synthetic progesterone, which is called progestin, and then you had the placebo group. And so the study was actually stopped prematurely because they noticed there was an increased risk of blood clots and stroke. And then there was a concern for breast cancer in the estrogen plus progesterone or progestin, really, because they were synthetics at the time. And it was actually, at the time, it was so well published, the information, like in the media, doctors actually found out through the media more than through, we never got like a little email that's like, hey, by the way, this is coming out. Like patients were just starting to come straight to us and saying, oh my gosh, I got to get off HRT. I got to get off HRT. And so the prescription rate at that time was somewhere around 70% of women were on hormone replacement therapy who were good candidates at the time. And it went down to about 4% very, very quickly.
Wow, that is a
Yes.
dramatic impact. Oh my goodness, I didn't realize it was that big.
Yeah. And so it just became very like there wasn't a lot of at the time a lot of sort of information as to like, wait, what is, it was just the largest study that had ever been done. I think it was like 12,000 women. It was a very well funded study by the company, a pharmaceutical company. And so we kind of just almost used it as the Bible, right? Oh, HRT is bad. Everybody should be off of hormone replacement therapy. It's potentially has an increased risk of breast cancer and blood clots and stroke, so you should be off of it. And then and it's kind of has been the narrative. So if any physician was trained in the last 23 years, they were really kind of told the same narrative. And I'm 16 years out of residency, and I distinctly remember as an OBGYN, they said, well, you don't need to remember anything about, hormone replacement therapy because you're never going to prescribe. So don't worry about it. It's not a thing you need to worry about. So, and I'm an OBGYN. And so at the time, I really didn't know much about that. And now in the last probably 5, 6 years, there's been so much more attention on menopause and menopause care. And, people who are, in their late 40s and mid 50s have celebrities who are now aging who don't like it. Who don't like to have hot
They don't like
flashes.
aging. Yeah.
Yeah, right. You got these celebrities like Gwyneth Paltrow and Naomi Watts and Halle Berry and all these list of oh my gosh, the lady with a great TV show that was on ET. I don't know why. Drew Barrymore. All those ladies who have like, wait a minute, this is not okay. I'm not interested in aging like this. And so the education to patients has made people go back to look at those studies in the early 2000s and say, why is this the truth? Why do we believe this is the truth? And a lot of sub studies have been done from that and realized that the patient population was the average age of that patient that was in that study was in their like late 50s, early 60s. There were
Okay.
people who were started on HRT in their 40s, 50s, 60s, 70s, 80s. Like everybody was in the same lump of patients. So that was one big fault of the study is they never distinguished between a 50-year-old who was within 10 years of menopause starting hormone replacement, a 60-year-old, a 70-year-old. Like there was no distinction on those things. Really, when they went back to look at the estrogen only arm, the people who had hysterectomies that only got estrogen, they didn't get progesterone at all. Those women actually had a decrease in breast cancer. They actually had
Really?
less breast cancer. So,
Okay.
and
What,
they
estrogen only
estrogen only
had,
arm. It was the
huh?
estrogen plus synthetic progestin arm. And remember, the estrogen then was not bioidentical, it was synthetic.
Right.
So it was, yeah, Premarin, our sort of classic. So both of them were synthetic at the time. So fault two of this study was that the progestin arm was the one that had the breast cancer risk, not the estrogen only arm. They actually had a protective effect on there. That
Oh
that was
my
never
gosh.
said.
Yeah, that I did not know that. That is fascinating. Okay.
Yeah. And then the third fault here is that we don't even use that regimen anymore. Like none of us use that. And
Right.
that kind of, synthetics have really kind of gone by the wayside. And so none of us are even using those therapies really anymore. Because I mean, I don't know how many women in your community, but if you tell them, hey, I would love to give you this estrogen that's made from horse urine and it has 16 different metabolites of estrogen, they're going to be like, no.
Yeah,
So
no, thank you.
so most of us don't do that anymore just because that's kind of come out of favor for the way that we sort of see the world and all those other things with sustainable medication. So there was a lot of, since then, people who've done many, many, many sub-analysis on the Women's Health Initiative had realized that the health of the patient is the most important part. Like if you're 45 years old, it's much different starting a 45-year-old on HRT than a 75-year-old. Because by then, when they went through the menopause transition, their blood vessels have hardened and they've sort of it becomes more of a risk in someone who's 70, starting them on
Mm,
oral estradiol versus someone who's 45 who still has very pliable, flexible blood vessels from a
mhm.
from a cardiovascular standpoint, so blood clots and stroke.
Okay.
From the breast cancer perspective, there's been other studies like the Nurses Health Initiative study that was done with 11,000 women. There's been a lot of European studies, and and what they've realized is the synthetic progestin is where we're concerned about this increased breast cancer risk. And it's really been, when you look at even back then, it was an additional person per 10,000 people. So we're not even talking about, you have that sort of relative risk and absolute risk question. We weren't even talking about a huge substantial increase, but whenever when you're reporting something, it's always better to look more dramatic to say increased risk of, breast cancer as opposed to sort of talking about one extra person per 1,000. So over time in the last 24 years, for those of us to take care of menopause women, is we've realized that the age of the patient is important as far as their health status. And then also, are they at risk for any heart disease or breast cancer in the future? Then those are the patients you sort of look a little bit more closely as, is hormone replacement therapy an option for them or not? But most women are candidates for it.
Yeah.
And now there's so many more options for besides oral medications that even those risks go down even more because a patch, for example, has less heart disease risk than an oral medication. So there's a lot of things that have suddenly come out in that 23 years that we kind of jumped the gun on saying it's bad for everybody when that's not necessarily the case.
Okay, so two follow-ups for you on that. I have heard, and tell me if this is true or not, that that increased risk of breast cancer went something like this, like it was 4 in 10,000 or 1,000 or something like that, who were not getting HRT. It only went up to like 5 in 1,000 or 10,000 of people who
Yep.
were on HRT. And is that what you mean by that
That
one
one extra
person?
person. Yep.
Okay, so it's like
Yep.
technically 25% increase, but like really not much in terms
Yes.
of number of people. Gotcha. Okay. And then it sounds like the second thing you're saying is that you really have to consider the risk of HRT as you're thinking about that. And that's cardiovascular risk, mainly risk of blood clot, stroke, heart attack, as well as breast cancer, right?
Yeah, yeah. I mean,
Okay.
breast cancer is really, I mean, to be honest, breast cancer is 1 in 8 women, right? I mean, this is a risk for everybody, really, because that's a high percentage.
That's a lot.
So, yeah, exactly. So the patients that we sort of steer away from an HRT would be more of someone who has high risk of breast cancer because they maybe have genetic reasons, or maybe they had a biopsy in the past and they're in that hyperplasia category, like they're at higher risk. And so those are the patients we may be a little bit more cautious related to hormone replacement therapy. But the heart disease risk is more, someone who smokes, who's over the age of 35, they may have uncontrolled high blood pressure or uncontrolled diabetes, and they really need to work on the metabolic aspect of their health first before they get on an extra thing like hormone replacement therapy. Might be someone who we would kind of have a good informed consent conversation with.
Yeah.
Not to say they're not a candidate, but that we need to make sure that we're having a good informed consent about it.
Okay. And
You know
then,
what I mean?
yeah, exactly. One other thing you had mentioned is that you said the risk is actually lower with transdermal forms of estrogen, like a patch or something, as compared to a pill. Now, that's important to this community of people with migraines because many of us have auras. And of course,
Yes.
aura also increases your risk of stroke just a tiny bit. And so for it sounds like for us, people who have migraine with aura, maybe the better decision then would be to take a patch. Is that correct? Or are there other forms of estrogen that we should ask our doctor about?
Yeah, yeah. So yes, transdermal application would be better. Now there
Okay.
are FDA approved, like Eva Mist is a transdermal estrogen you can spray on you. There are Divi Gel is an estrogen gel. So there are FDA approved ones that are not necessarily a patch that are
Okay.
still transdermal. And then obviously you have compounding, right? You have compounding outside of the FDA prescribed medication. So there are other transdermal besides the patch.
Okay, and by compounding, you mean like the creams that are made by a special compounding
Mhm.
pharmacy? Okay, gotcha. And so, do you have thoughts about what the best choice is for somebody who does have migraine with aura if they look at the pros and cons and decide, okay, I want to do this? Um, any recommendations as to, which for like is any kind of transdermal okay? Or are there certain forms of estrogen that are better than others? Should you go for an estradiol? Should you go for like the lower dose, or how do you think we should ask our docs about this?
Yeah, so there are three estrogens in the body. There's estradiol. This is the I'm 25, life is awesome, things are great estrogen. There's estriol, which is really only present when you're pregnant. And then if you happen to be on a biased cream that's compounded, that's estriol. Or say you pick something up off a counter, it's going to be estriol. And then there's estrone, which is the pro-inflammatory fat estrogen that nobody wants. So
Okay.
we don't ever compound
Nobody's
that
going to take
because
that one.
nobody's like, yes, the one that's made in my fat. Let's sign up for it. Like nobody does that. So it's really the estradiol, which is the 25. I feel awesome. Life is great. I'm invincible estrogen that most people use in the patch or the cream, like a Divi Gel or the mist. Those are all FDA approved estradiol.
Okay.
What I find with people with migraines is some of them are very sensitive to things, like very
Hmm.
sensitive to medications. So sometimes I can't just give them an estradiol patch because I almost need to like baby step it up a little bit with their estrogen. So sometimes
Hmm.
I have to, give the caveat that I'm integrative medicine trained. So I'm not opposed to compounding and alternative medicine. I'm boarded in integrative medicine and functional medicine. So to me, that's like part of my toolbox for patients.
Hmm.
So sometimes I have to do like a combo of a week estriol and estradiol to kind of ease them into that because they're prone to migraines. So I have to be careful not to like hit them with what, a 47-year-old that doesn't get headaches with because it's miserable. So, sometimes I do find those patients to be a little more sensitive. So I think and it's not a one size fits all. There's certainly patients who do better with creams than they do with a patch, or they do better with a dosing every other day, or only cycle specific. Like there's a very personalized approach to those things, because I've had patients who you barely give them a little tiny cream and they're like the happiest people in the world, and then you give them like the other person, you give 5 levels of the patch and they're still miserable. And you're like, wait a minute, how do I, you guys, like, what's going on here? The physiology is something that you don't know until you start trying with patients.
Yeah, that makes sense. And a lot of people in my community have had their genetic testing done, so they know exactly how their body makes, converts progesterone to testosterone and testosterone to estrogen, and how their body makes toxic metabolites. So I think everybody here is like, yep, yep, we're all going to be different about that. Yeah.
Yeah, it's
Okay.
true. I mean, I literally, we do blood tests in Western medicine because we don't use a lot of like Dutch tests, for example.
Yeah.
I love the Dutch test, but they don't do it because it's not covered by insurance. And but you can certainly see like someone could be on very small amount of cream and then their estradiol level is like 2000, and you're like, what? How is this possible? And you can imagine that the pathways, if you know the Dutch and can picture it, you can imagine that the pathway for them is different than the person that maybe has a normal of 50 estradiol by being on a cream. Like they may be converting from testosterone, or they may be specifically shoving it all down that one pathway. Like there's a lot of different ways to do it.
Yeah, yeah, fascinating. Okay, so then knowing that there is a slightly higher risk of stroke, and we need to be kind of careful about dosing because it could worsen our migraines. What are the benefits?
Oh my gosh, how much time do we have? So the benefits.
We want to hear them all.
I mean, the patients that choose to do hormone replacement therapy, even with migraines, they're coming to me saying, I can't sleep, I can't get to sleep, I can't stay asleep. I'm angry, I'm irritable, I hate my coworkers, I hate my husband. My vagina's dry, everything, my skin's changed. I just don't feel like myself. I
Yeah.
don't feel like myself. This body is not mine. Somebody
Yeah.
else's is body. So those patients have often tried to dial in their nutrition, dial in their lifestyle, do the weights, do the supplements, do the things, maybe tried herbal therapy, and it's not doing it for them. It's not, they don't imagine, we now spend 30 years on average in menopause, right?
Wow. Yeah.
So a third of our life is in this stage.
That's a very big chunk. Yeah.
Yes. So sometimes I say to patients, how do you want that 30 years to go? And this may be completely resonate with people or not resonate at all, but I sometimes think of this as like an epidural in labor, right? You can have a baby without an epidural. It happens. It will come out. I promise. But do you want to? That's
Yeah.
really the choice, right? Like in my mind, it's the choice. Like, um, how do you want that labor to go? How do you
Yeah.
want that to go? And for some women, they've decided, I think hormone replacement therapy makes sense for me because I want to live differently than I am, and I've tried these other things. Or maybe they've decided that's the way they want to go.
Yeah.
And it's not for everybody. Some people don't need it, but for the women that do choose it, it's because they find out that they get the relief of being able to sleep. So I describe to patients a lot of times, each of those hormones kind of has a role. So progesterone is the hormone in your body that helps relax your brain, to get you to sleep, to stay asleep. It works with the GABA receptors in your brain to calm you down, to make you feel less irritable, anxious, annoyed. You have less apathy, like you feel calmer, and it helps in your joints to help less stiffness. You don't feel stiff or achy. You don't pull your neck when you walk out, try to get out of bed in the morning, like when you get into menopause. It calms the heart down, so you have less heart palpitations. Those are all the effects of progesterone. And there's more, but those are kind of the big ones. Estrogen is the hot flashes, night sweats, memory. Why did I walk in this room? What's my neighbor's name? What's that kid I went to high school with? Dry skin, dry vagina, skin, urinary, more UTIs, more BV, all of that is estrogens. Specifically, like joint pain and bone pain, it's very much estrogen, like the frozen shoulder, the,
Ah,
achiness, all estrogen and libido.
interesting. Yeah.
And then
Wow.
testosterone is focus, energy, um, building muscle mass, libido.
Hmm.
So when there are patients that are coming, they usually come for symptoms and say, I'm having these symptoms. What are the things that we can do to fix? And when we talk about HRT, it's really more symptom driven from what we decide to give to them in particular. Does that make sense?
Absolutely. So does HRT, newer data with bioidentical HRT, does it reduce your risk of heart attack?
Yeah, so there's a lot of new things. So in the way that we have it listed in sort of medicine, as we say, okay, estrogen is for hot flashes, for example. But
Hmm.
what we know is that estrogen is vital for heart health, for bone health, for muscle health. Like we have all these other parameters that we know that estrogen is very, very useful for. In fact, there was, I don't know if you've read The Menopause Brain by Lisa Monscani, but that book is fantastic. She's the first person ever she's a neuroscientist to ever get a marker she can literally see on imaging of where estrogen goes in the brain.
Wow.
It's super cool. And she was able to then show what her theory is that we have twice the rate of Alzheimer's because women go through menopause and that transition kickstarts them that direction, and inflammation and all the other things are a genetic setup for you, right? And then now menopause kind of throws you over there into that category. So we have twice the rate of Alzheimer's, and her idea was let's show the value of estrogen from a brain perspective. How does it help keep our brains healthy and prevent disease? And so it's a great book for those of the people who love the idea of what does estrogen do for the brain. And I think in the next 5 years, we're going to get indications about why we would use estrogen for other things besides hot flashes,
Symptoms.
right?
Yeah, exactly. And I think
Yeah.
that brain piece is so important. Obviously, migraine is a brain disease. If you keep your brain cells healthy, things are just going to go better. You're going to get fewer
Mm-hmm.
migraines. You're going to get less of all the things that go along with migraine, whether that's brain fog or anxiety or depression or insomnia, all of the things that go along. So what helps people so often is to focus on keeping the brain healthy as a whole. And then, of course, your headaches get better as a byproduct. And so it sounds like we have pretty good imaging data that estrogen is a part of keeping your brain cells healthy.
Yeah. And, there's a lot of other studies in other countries about testosterone and its value in bone and muscle, right? We
Hmm.
lose muscle and bone as we age, and the value of how testosterone can actually be, and heart can be like a wellness for those
Yeah.
sorts of things as we age. I think a lot more of that will come up too as people are putting more focus on menopause in general and what happens to people as they age.
Interesting. Now, I think I have is bone health related to estrogen as well, or is it really just
Yes.
testosterone?
Nope. No, estrogen helps with collagen. And so when you're talking about collagen for bone and bone turnover, right? Bone needs to need to break down the bad stuff and build the good stuff. So estrogen is key in that osteoblast activity. So this is why when, people are starting to have osteopenia, we tell them to do weight-bearing exercises to put pressure and stress on the bones to turn over. But estrogen, when you're young, kind of like bosses the bone around and kind of like, you need to be doing this. You need to have lubrication and fluid in your joints. You need to have collagen. Like all that stuff is what estrogen does. I actually joke with my patients that I sort of talk about estrogen as like the bossy aunt in your family. Like
Bossy.
everybody has one that like is in everybody's business, right? And they know mine's Aunt Lisa, and Aunt Lisa knows I talk about her all the time. Like she's the bossy aunt in my family. Like she's up in everybody's business and she knows everything about everybody. And there's an estrogen cell on there's an estrogen receptor on every cell in your body. So estrogen to me is like the bossy Aunt Lisa. Like she's involved in everything. So when she goes away, the inmates go rogue.
Wow, the inmates go rogue. Wow,
The
interesting.
cousins do what they want to do.
Yeah, I did not know there was an estrogen receptor on every cell in your body. That's fascinating. Huh. Okay.
Yeah, I mean, this is actually some of the stuff we're seeing now with women using estrogen on their face. We have estradiol and estriol receptors in our face. So now people are putting their vaginal estrogen on their face to improve their skin, which is awesome. There's
Does
some
that
new
help?
data. Oh
Wait,
my God,
wait, does that help?
it's awesome. I do it. Yeah,
Really?
yeah, yeah.
That's
Yeah, so
fantastic. Okay.
you can do like a biased cream, and I always put it. I mean, like right now I like to because the light's bad in here, but You can put it on underneath your eyes and along. You can put it anywhere on your face, really. But it's great because it does
Wow.
improve collagen, helps turnover, sort of helps your skin look a little bit more youthful. So there's a lot of like
Oh.
products that are now being sold by third parties with estriol and estradiol in them.
Oh my gosh, that's fascinating. Okay, that's a
Mhm.
super useful tip too. I did not know that. Okay,
And
new
you can literally
application for the
you can take the
estrogen.
estradiol vaginal stuff and do it if you want. If you want to old school, kick it old school and cheap, you can use this stuff if you want.
That's very easy. Don't have to get another prescription. That's great. Okay, love it. Okay, and one last thing. This whole issue of estrogen toxicity, they talk about it a lot in functional medicine. I never heard anything about it in regular MD school, but then again, I'm a neurologist, not an OB. Do people talk about this estrogen toxicity being a big deal? Do you have to try to clear that stuff off? Should you be tested? Is the 16 hydroxy really the one that's associated with cancer? How do we frame all that?
Yeah. So, I think the one thing you have to realize is those are two different languages, right? Western medicine, we don't use those terms. We don't
Right.
look at metabolites of hormones. We don't I don't want to say don't care, but we don't use it as for anything clinical.
Right.
In functional and integrative, and in fact, even in Western medicine, we put people on HRT. We don't ever check their blood tests. We don't have. We just sort of go, oh, it'll be fine,
Yeah.
which I fundamentally disagree with anyway, because I've many times
Same.
found people with crazy high levels, and it was just a standard medication. So it's
Yeah.
like, well, I think you should probably test for safety.
Yeah.
But but yeah, from then when you're talking about functional medicine or integrative medicine, first of all, in OB, that didn't tell you any of that stuff. But in functional medicine, what we are about is like, how do we get the body to heal? How do we use what we know about our body? How do we our uniqueness and our personalization? How do we make that help us with whatever goal we're doing for health? And so the metabolites, or figuring out where those hormones go, is important, especially if you're not going to use HRT, because you want to figure out what is the step I can do to regulate my hormones better. But even with HRT, I often will do Dutch tests. This is really the Dutch test we're talking about.
Mhm.
And because often patients will want to know, well, what does this hormone do to my body? Like how do I respond to it? And
Mhm.
so I think it can be very valuable to understand, how does this hormone replacement therapy how does it respond in my body, whether or not it's a good or bad pathway. And I do think that some of the reasons why this is used a lot, even with hormones, is because there's some people who are trying to study like breast cancer patients. And if we put them on tamoxifen, are they truly being blocked? Like, is their estrogen actually truly being blocked? So there's some studies that are being done around, which I think is awesome, where they're using the Dutch to try to see maybe those patients are not actually being fully blocked and they're going down the bad pathway. And those are the people with maybe recurrences, right? Like
Mhm.
they're like it's going through and it's shooting this direction and not this direction, the green pathway. And so
Mhm.
maybe potentially these drugs, while they're not a universal fit for everybody. So I think that's kind of cool stuff where people might in the future use it for understanding what's the right personal treatment for someone with breast cancer, and how to see what's happening with their estrogen if they're like an ERP or a positive patient kind of thing.
So could you maybe start some HRT if you know genetically that you are prone to making these toxic metabolites? Start your HRT, wait a couple months, grab a Dutch, see where you're at, see what your metabolites are doing, and then maybe make decisions about dosing. Like, would that be a reasonable thing?
You can. I mean, you can make decisions about dosing. You can also make decision on the type that you're taking, right?
Ah,
Maybe you're on a patch and that's not working with your chemistry, and maybe you prefer a cream. I don't know. Like there's ways you can
got
do both
it.
the type but also the dosing.
Okay, so yeah, maybe changing formulation. Okay, cool, got it.
Or even if you're
Awesome.
on, say for example, you're on an estrogen cream and you feel great on it, this is what you want to do. You can still use the Dutch in some ways to do lifestyle changes, right? And to figure out, well, maybe I need to um, do something for liver support, or I need more GI support, or whatever it is from a lifestyle standpoint to dial that piece in too.
Got it.
Yeah.
Okay.
If you're open to HRT, it's something that you're wanting to do. I do think there's a ton of longevity benefits for using it. For sure, brain, muscle, bone, heart, skin. I mean, prevention. There was a very great study, believe it or not, funded by Medicare, which like never happens, where they literally took 65-year-old women in Medicare, like a population, and they just gave them vaginal estrogen and saw how many people did not go into the ER or urgent care for UTIs. And ironically, it dropped by 60%. But it was like so drastic that we should think of it sometimes, even especially on like a vaginal thing, of like prevention in like this prevention category, because a lot of women get very sick with UTIs
I
or
do.
and get end up being very, very sick. And so those are things that we might in the future see where it's more of a thought of prevention. You know what I mean?
Yeah. Yeah. Fascinating. Wow, that's really interesting data. Is the vaginal estradiol ring a transdermal HRT?
Yeah, so that's a vaginal option. So rings, the ring is S-ring. It's a 90-day ring that you put in the vagina. So we don't really call that transdermal because
Okay.
we're thinking of dermis more like our skin. So estrogen cream, like Divigel or Evamist or a patch is more like transdermal. And then vaginal can be creams, suppositories, rings, you know,
Okay. So
lots of
that's
things.
the local benefits only. You're not going to get systemic benefits from any kind of a vaginal ring, cream, anything.
Nope.
Got you. Okay.
Yeah, in fact, you can actually have a breast cancer patient can take vaginal estrogen
Oh,
because
that's good
there's
to
no
know.
systemic risk. Yeah.
And how do you feel about testosterone? It sounds like some of the benefits are energy, muscle building, libido. Anything else? Talk.
Um, yeah, I mean, I love testosterone. I think I have a hard time believing that at 25 it's great, but at 55 it's not great. I don't get that, how it's natural in our body and it's something useful and it suddenly becomes not useful just because there's no FDA approved medication for females. I just think that's
Right.
weird.
Yeah.
When in the UK and Australia they have a patch for testosterone. Companies have been trying to get testosterone for females since the 80s, but for some reason there's this block to getting it approved. So I think that testosterone has a lot more benefits than what we know because we just don't study it because there's no
Mhm.
product. But I
Yeah.
will tell
Yeah.
you that there's actually a company trying to work on testosterone. I don't know why it would be intranasal because I don't know any woman that wants to snort testosterone, but hey, you do you, buddy. You do you.
Whatever.
So whatever. I'm sure it was a man running that company, but like, and so we'll see. But I think testosterone, for what I notice with women, is that they focus energy in the afternoon. I'm 47. I take testosterone, and I described to my husband that I love you, but I really like you now. Like, like he swipes by me, and I'm like, hey, hey. And before I was like, I could care less. I'd rather go to
Yeah.
sleep. Like, eh.
Yeah.
So, there's sort of, I think there, from a libido, what it does for libido specifically is it improves blood flow to the genitalia, which is something that women lose as we age. And then also it improves the brain's response for dopamine that says, oh, this was a rewarding activity. Do you remember? Like this was actually, so it
Mhm.
works in the brain and locally to help for women for libido. I do find, like I said, with people who have migraines, that you just have to be a little gentler on finding the option. You can't just sort of hit them at the high doses of HRT. You need to start always at the lowest and you need to sort of give more time to see how they do.
Yeah, and I'm guessing that giving more time helps with somebody who has problems. We've got a question here. I started HRT, it included testosterone, but my headaches increased to near daily. I'm guessing the answer is go a little slower and lower dose. Like you were saying, maybe start with a cream first, not a patch. It would.
Yeah, and some of it has to do with the reason what triggers your migraines. So, for example, if I have a patient who gets migraines because they don't sleep, whenever they don't sleep, well, then I'm going to be focusing on their HRT, really on progesterone to get them to sleep. Like, right, what are
Mm.
the migraine? I mean, I had migraines for forever, and then I did
Oh,
Botox for migraines, and they went away, and it was amazing.
yeah.
But there are certain, usually people have triggers that cause them to, they know their triggers, right? So if it's like sleep, then progesterone. If it's cycle, then I think about estrogen. If it's whatever the triggers are, you sometimes have to focus first on that and go low and slow on those
Mm.
patients. So I often will, for example, start progesterone first, then I may add estrogen. Like I sort of kind
Got
of
it.
slowly do add these things so then I know that they're kind of not getting a migraine from that particular drug. Like I would never start a migraine person on estrogen, progesterone, testosterone all at one time.
Got it. Right, right. Because you have to monitor what happens. That makes total
Yep.
sense. Yeah. And a question about that. If you are, say, already 70, does it make sense to start HRT at that
So I would tell you from a Western medicine standpoint, they would say, no,
point?
you
Okay.
should not do it. I will tell you that, have I done it? Yes. What I want to know, I often will require that patient to get a coronary artery scan. Like, what do their blood vessels look like from a cardiovascular standpoint, just to understand, are we are we doing, I mean, to be honest, like sometimes some 70-year-olds are healthier than 20-year-olds.
Fair.
Like, I mean,
Fair.
I've had some patients
Yeah.
that I'm like, dang, you're healthier than my 25-year-old in the practice. So I always get a coronary artery scan just to make sure that there's no clots, I mean, no blockages in their coronary vessels. I will talk about lifestyle. We'll talk about what is the why now, like why are you considering it? I would say most of the people that are thinking about it from standpoint in their 70s is because of the vaginal issues,
Mm,
UTIs, dryness, discomfort, and that local is very different than systemic for risks. So
mm.
I don't have any problem on a 70-year-old who's like, I want the cactus thing to go away. I'm like, let's do it. You know what I mean? Like I'm game. Like, because there's very few risks. So, and that makes someone's quality of life a lot better. If they have
Yeah.
incontinence, it will improve their incontinence. If they have
Wow.
dryness, like there's a lot of benefits for local estrogen. So I don't have a problem dishing that out. I think when we're talking about systemic, we really want to understand, why did they go through the whole transition and why now? Like,
Yeah.
what's going on?
And they could probably do progesterone to help with sleep and testosterone to help with libido, muscle mass, energy. Those would be okay, right? It's just the patch estrogen or the systemic estrogen that we would have second thoughts about. Am I understanding you correctly?
Well, all of it's systemic if you're putting it on, whether or not it's oral or whatever. But the risks, yes, are higher with estrogen versus progesterone or testosterone.
Okay.
But a lot of times, to be honest, those patients really only need a tiny bit. Like, I don't even think about patch. When I think about that, I think about even a tiny bit of cream goes a long way. Do you know? Like, if you
Mm-hmm.
haven't had anything, a tiny bit goes a long way.
Yeah.
Versus
Yeah.
like a 45-year-old, you can't give them a tiny bit of estrogen. They're used to being having so much more. Does that
Okay.
make sense?
Yeah. Yeah.
That's
They
my
won't,
personal,
it
but
won't notice
again,
it.
that conversation is for sure outside of Western medicine. Because if you were 70, you walk into a standard OB/GYN, they're going to be like, no.
No. Yeah.
Yeah. Hormone replacement therapy is not meant to bring you back to 25. Like, it's not meant to, I mean, I don't want to burst anybody's bubble, but it's hard to get back to 25, like
Yeah.
even with hormone replacement therapy. So, I mean, I'm 47. I mean, but I think I would pick like 40. I'm a little smarter then, right? Like 25, I still
Yes, I don't
did
want to be
some silly
25
stuff.
again. That was med school. That was way too much work, right?
Yeah,
No.
maybe a little bit more mature.
So here's an interesting one. What if somebody has estrogen levels that are already high in menopause, having been tested genetically or with a Dutch? Should you skip the estrogen then and maybe just do progesterone and testosterone or take it based on symptoms?
Yeah, so a perimenopausal person is a perfect example of that. They're going to have, because they have the roller coaster on the way down, they're going to have, sometimes it's high, sometimes it's normal, sometimes it's low. And they'll tell you that. They're like, sometimes I feel great, sometimes I feel terrible, sometimes I'm okay. Like, I'm up and down, like I'm a mess. So I can say that because it's literally me right now. So like, so testing them, this is why Western medicine argues against testing, because they say, well, you could test somebody and 3 weeks later it's like completely low, and then 3 weeks later it's normal. Like, what are you going to do with that information? So I often don't use estrogen, because if you're going to add estrogen to somebody, you may potentially, when they're high, make them even feel worse, right? So if there's someone who, say, has still having cycles but having perimenopausal symptoms, or even they may, if you put them on estrogen, they may start having acne, their breasts are going to bother them, they get heavier periods, they have all the high estrogen type symptoms. So I usually go by symptoms, but I also go by like, what stage are they in their perimenopause journey? So there's 3 stages. Where are they likely to be? And I often counsel them saying, I don't think that you're ready quite for estrogen. If we are, then we can add it, but just here's the side effects if it's too much for you, if that makes
Yeah,
sense.
that makes total sense. Yeah, yeah, that seems like a really good way to handle that situation. Do I understand that the Aura and HRT combo has a small risk for stroke? Yep, it does. Lower dose estrogen and transdermal and bioidentical are all ways to reduce that risk. Am I right in saying that?
Yeah, so estrogen in general, whether or not it's a birth control pill or estrogen, there is a slightly increased risk for people with aura for cardiovascular disease. The transdermal is the safer option compared to oral for sure.
Okay.
It's not a contraindication. So if you had aura, we don't say, oh yeah, no, never ever estrogen. We want to understand a little bit more about the neurological impact, right? Because there are different people have different kind of symptoms and risk factors that we're talking about.
Yeah.
But yes, transdermal is definitely typically used more often than an oral option in that scenario.
What do you think about compounded like estrogen mimics, soy, yam? Yeah. Do you think those do anything, or do you really just need the prescription stuff to get the job done?
No, I mean, there are people who use plant-based. Well, first of all, bioidentical hormones on a compounding are plant-based anyway. I mean, a lot of medications are plant-based, but they're plant-based anyway. But if you're talking about, say, Progest cream, which is made from wild yams, then like the kind you
That's
get over
it.
the counter,
Yeah.
then yes, I mean, I have lots of patients. I have PMDD patients, I have PMS patients, I have menopause patients who use it. There's no I'm not against anything, to be honest. There are people who it works great, right? Like I have patients who swear like it's the best thing ever. So I'm not, if it works, great. Do I think that in general, progesterone compound or progesterone in general works better than yam? Yes. But that's just from patients who I see, right? In general, I see them come back. But there are a lot of patients, especially younger patients, who are using it for cycle support or migraine support in their luteal phase that use Progest cream, and it works great for them.
I just want to say thank you so much for being here. We are just so grateful to you for sharing your time and expertise. I appreciate you so much.